on the cardiovascular updates in these guidelines. We now have drugs that are diabetic agents that lower a person's cardiovascular risk for both primary and secondary prevention. And so I recently have given this talk just this week, actually, for the Pennsylvania Medical Association seminar, the winter seminar. And I've also given the same talk for the West Virginia Medical Society as well. So these are all updated guidelines, and we're gonna focus on medications that reduce a person's cardiovascular risk when they have specifically type 2 diabetes. I like to refer to it as my cardiabetes talk, because again, it's focusing on cardiovascular risk reduction. So without further ado, let's get started. I don't have any disclosures or conflicts of interest to report. And next slide. So let's start with a true or false quiz. Are there diabetes drugs that reduce cardiovascular risk? True or false? I kind of gave that away. Yes, we do have now drugs that reduce cardiovascular risk. Are there diabetes drugs that are approved for primary prevention of cardiovascular disease? Yes, both primary and secondary cardiovascular prevention. And are there diabetes drugs that improve renal function? Absolutely, yes. And there are drugs that you can hit 2 birds with 1 stone. So drugs like GLP-1 agonists, which we'll go through in depth, that can reduce your cardiovascular risk and improve your renal function, and have a multitude of other effects, which we'll cover. So moving on to the next slide. So what's new in the 2021 guidelines? There are dedicated decision pathways for patients with both diabetes and heart failure, atherosclerotic cardiovascular disease, and chronic kidney disease. Next slide. Oops. Somehow I lost you. Somehow I lost yours, so I'm gonna pull up mine, Mitra.
Okay, sure. Let me make you co-host. So
here we go.
You should be able to
I have mine up. So next slide should show. Yep, for some reason it just
is this slide okay?
Stopped on my screen. There we go. I don't know what happened, but it left my screen for a second there. Sorry about that. So cardiabetes is a term that refers to the fact that now we have cardiologists who have been faced with, their patients that have atherosclerotic disease or heart failure, and they're seeing our type 2 diabetes patients, and they have more of a role in treating our patients with diabetes. So the term cardiabetes was established. Next slide, please. So our objectives today will be to discuss the anti-diabetic agents that reduce cardiovascular risk and improve kidney function. We'll focus on the GLP-1 receptor agonists. That stands for glucagon-like peptide. And we'll also focus on the SGLT2 inhibitors, and that stands for sodium glucose cotransporters. We're going to review all the available agents in both of those classes. We'll talk about the mechanisms of action and the benefits and the risks. Our goal is to become familiar with updates from the new ADA guidelines in January. Next slide, please. So why must we act, and why is this important? So atherosclerotic cardiovascular disease is the leading cause of morbidity and mortality for patients with diabetes, including cardiovascular disease, cerebral vascular disease, and peripheral arterial disease. There's roughly 37 billion in cardiovascular related spending per year associated with diabetes. Next slide, please. So this was a landmark trial coming out of the Cleveland Clinic, published by Dr. Steve Nissen. And I was privileged to be one of his mentees. He was my mentor at the Cleveland Clinic. And he published this back in 2008. This was really significant because this was a trial that basically said, from here on out, every single diabetes drug that's introduced to the market needs to undergo rigorous testing to make sure that it doesn't cause cardiovascular harm as did the effect of rosiglitazone show on myocardial infarction and death from cardiovascular causes. And rosiglitazone is of the class, they're called the TZDs, or thiazolidine diones. So this prompted, and we'll go on to the next slide, a series of trials. So this is a really busy slide. And it's just really meant to show you that since Dr. Nissen's work, there have been many trials, and I haven't included all of them. This goes from 2013 to 2020, and it shows mainly the ones that I'd like to focus on today, which are the SGLT2 inhibitors and the GLP-1 receptor agonists in the pink and in the orange. But it just goes to show all of the work that's been done to make sure that new agents introduced for treatments of diabetes have rigorous cardiovascular testing to make sure that we're not doing more harm. Next slide, please. So this is a review of the non-insulin diabetes medications in the United States. And again, focusing on the SGLT2 inhibitor class and the GLP-1 receptor class that's over on your left-hand side. And so SGLT2 inhibitors are oral agents. They include the gliflozins. If you think about it as a gliflozin, you won't forget it. So that's ertugliflozin, dapagliflozin, canagliflozin, and empagliflozin. I included the generics, all the generic names to the left, brand to the right, and then GLP-1 receptor agonists. These are predominantly injectable agents. There is recently one new oral agent on the market that's called Rybelsus down here. It's second to last. So these are the tides. I like to think of them: LIRAGLUTIDE, Exenatide, Exenatide, Dulaglutide, Exenatide XR, semaglutide injectable, and semaglutide oral. And then Albiglutide is now off the market. I also included just the other classes for your benefit and as a reference slide, but again, I'm not going to be discussing those in depth today. Next slide, please. So this comes out of the ADA's 2021 guideline, and I want to just call your attention to the highlighted portions. So we're gonna zoom in on this. Again, it's a busy slide, and I'm sorry for that, but we're gonna zoom in on the pertinent parts of this. So the SGLT2 inhibitors over here on the left. Can you see my pointer when I'm using it on here?
We cannot see on our end.
Okay.
You would, if you wanted to share your screen, I think then we could see your cursor. If you wanted to try that, we can certainly.
Let me share here.
So I can stop my screen share, and at the bottom you'll see that green upward arrow. Yes, that's perfect. So we can see your screen now. You could even maybe maximize the PowerPoint also, and then, oh, that's perfect. We can see your cursor now.
Great.
Thank you, Dr. Giordano.
So using my cursor, I just want to call your attention to these highlighted portions. So your SGLT2 inhibitors and your GLP-1 receptor agonists. And this is, again, a reference slide for you in clinic, really. So now the ADA, and this is for the past few years, but they've been adding to this cardiovascular effect and the renal effects, which we're going to go through in depth. So next slide, please. Let's see. Oh, there we go.
There we go. Yep. Thank you.
Sorry, it wasn't advancing on mine. So to zoom in on the GLP-1 receptor agonist, you'll see at the top are headings of efficacy, hypoglycemia, weight, cardiovascular effects, cost, is it oral or sub-Q, and the renal effects. So GLP-1 receptor agonists do have high efficacy. They lower your A1C. They are not associated with hypoglycemia, which is wonderful. They cause weight loss, which is also another wonderful benefit. In terms of their cardiovascular effect, they have benefits for atherosclerotic cardiovascular disease. Specifically, the data is most strong for dulaglutide, liraglutide, and semaglutide. Neutral for heart failure effect. They are high cost, but I believe coverage is becoming better as this evidence-based medicine is coming to light with insurance companies. And again, we talked about most of them are sub-Q. There is one oral, the Rybelsus. Renal effects, they do have a benefit. This benefit is a reduction in albuminuria, reduction in, or a decrease in the time it takes for someone to go to end-stage renal disease. So many renal benefits as well. And then I can't see, I'm gonna move you guys a second. There we go, additional considerations here. I wanna point out that there is a black box warning, this risk of thyroid C-cell tumors. Those studies were done in rodents only. It's never been performed in human trials. And so that is something that I tell my patients about, but I also make a mention that it is only in rodent studies at this time. The biggest adverse side effect of these agents is your GI side effects, so nausea, vomiting, and diarrhea. We try to circumvent that by starting at a very low dose of therapy. And so for instance, if you're using, say, semaglutide or Ozempic, then what we typically do is start at a low dose for the first month and then bump it up the second month and then bump it up the third month to try to avoid those GI adverse side effects. Pancreatitis is definitely the very worst reaction that has been reported. It is rare. Nonetheless, it's something that patients need to know about. You can also have injection site reactions because, again, these are injectables. Moving along to the next slide here. So GLP-1 receptor agonists are called the incretin drugs. I listed them again here for your reference. Liraglutide, all the glutides, which we talked about, but again, just another slide for your reference. So this incretin effect, what are the incretins? There are two main incretins that we have. Glucagon-like peptide 1, or GLP-1, and gastric inhibitory peptide, or GIP. So these work to stimulate insulin release and inhibit glucagon release. By these two mechanisms, they lower blood glucose. You'll also remember from an earlier slide, the class of medications called the DPP-4 inhibitor drugs, which are listed right here in the blue. And the DPP-4 enzyme inactivates incretins. So that's how the DPP-4 inhibitors work, like Januvia. Again, I'm not going to focus on the DPP-4 today. I just wanted to tie that in with, you know, how our incretins work and what they are. Oops, excuse me. So incretins have many actions on different target tissues. You can see here in the brain, they're neuroprotective, they decrease appetite. In the stomach, they lend to decreased gastric emptying, making a person feel more full, helping assist with weight loss. From the pancreas, they increase insulin biosynthesis and increase beta cell proliferation. They decrease beta cell apoptosis. At the level of the muscle, increasing insulin secretion and decreasing glucagon secretion. And then at the level of the liver, decreasing glucose production. We mentioned they are cardioprotective. And I have another slide that goes into the cardiovascular protective effects in more depth. This was published in Circulation recently, and this basically shows that through a multitude of different effects, increased glucose utilization, decreased fatty acid utilization, increased coronary flow, increased left ventricular ejection fraction, are all ways that GLP-1 receptor agonists improve and benefit myocardial or myocardium or heart function. Oops, excuse me. This, again, is a really busy slide, but I just wanted to point out to you that there are a multitude of benefits from GLP-1 receptor agonists on the kidney as well that lend to afferent vasodilation, so they reduce hyperfiltration and damage through the kidney. So let's talk through a case to break up some of that physiology. Okay, so case 1, John clogged artery, he's 64 years old, it's a Caucasian male, presents for severely uncontrolled type 2 diabetes. His A1C was 11.2%. He was diagnosed with diabetes in 1997. BMI is 29. He weighs 225 pounds. Vitals are stable. His diabetes is complicated by peripheral neuropathy. He has bilateral dorsal foot ulcers. His CKD and his GFR averages around 35. He does have a history of AFib, cardiac disease, ischemic cardiomyopathy, heart failure, ICD is in place, pulmonary hypertension, sleep apnea, hyperlipidemia, hypothyroidism, and he was recently admitted for decompensated heart failure. His diuretics are being titrated upward. And so this was, the cases that I present are all patients that are mine in clinic. So this patient's current regimen was Lantus 75 units twice a day, Humalog 10 units 3 times a day. Fasting blood glucose on this regimen was 200 to 300 with intermittent hypoglycemia during the day. He hasn't had diabetic education recently, and his wife is here with him, reports he's eating McDonald's fast food 3 times a day. So along with diabetic education, what is the next best step? Do we want to increase his insulin, add metformin, begin a GLP-1 receptor agonist and reduce insulin to eliminate lows, begin an SGLT2 inhibitor to reduce insulin to eliminate lows, or ban him from McDonald's? Does anybody have any thoughts? No answer is wrong. We're going to talk through them. And I don't.
Got a chat in too saying D and E.
C and E.
Okay, so let's talk through these. Why is increasing insulin not really a good option? Because we talked about the fact that he already had daytime hypoglycemia, right? And so adding on more insulin is just going to predispose him to hypoglycemia. And remember, insulin causes weight gain and fluid retention and hypoglycemia. So that's not an ideal option. Adding metformin is also not an ideal option because we talked about his GFR was around 35, right? So the guideline now for metformin is if a GFR is between 30 to 45, it's really not ideal to start metformin. If your patient is already on metformin, then the guideline is you can reduce it to 50% of the dose. So that would be 1,000 milligrams of metformin a day, but it's not ideal to start metformin with a GFR of 30 to 45. And then remember, if a GFR falls below 30, then metformin needs to be held. So C, begin a GLP-1 receptor agonist and reduce insulin to eliminate the lows would be my answer. And that is what I did with this patient. And we'll talk about that on the next slide. Begin a SGLT2 inhibitor and reduce insulin to eliminate lows is also something to consider. But because this patient's A1C is so high and uncontrolled at 11.2%, starting them on an SGLT2 inhibitor at this time would not be ideal because SGLT2 inhibitors act as diuretics. And so this patient is going to be going to the restroom constantly, not likely going to be as compliant with an SGLT2 inhibitor at this point in time. And then banning him from McDonald's is something that none of us are really able to do, right? Okay, so what I did was I started a GLP-1 receptor agonist and I reduced his insulin to eliminate lows. Again, I avoided the SGLT2 at this time because his blood sugar was so uncontrolled that it would lead to excessive urination, and his GFR is marginal at this time, around 34. He just got out of the hospital. He's on diuretics, so not really an ideal time to start your SGLT2 inhibitor or metformin. When we started the GLP-1 receptor agonist, I told you that they cause weight loss. So his weight went from 225 pounds to 213 pounds. And I don't take full credit for that because he was on diuretics as well. And they had been titrated up for his heart failure. So if we look at the results from when he initially saw me in endocrine clinic in January of 2018, A1C was 11.2%. And we got him down to 6.7% where he's hovered since. So pretty remarkable. Okay, So let's review the GLP-1 receptor agonist trials specifically surrounding cardiovascular disease. These include LEADER, SUSTAIN 6, HARMONY, REWIND, EXCEL, PIONEER 6, and ELIXA. Starting with LEADER trial, this looked at liraglutide or VICTOZA, and it showed that the primary outcome, which was a composite of cardiovascular death, non-fatal MI, or stroke for liraglutide versus placebo, was significant. So all the significant findings have stars. So significant versus placebo, all death from cardiovascular causes, there was a reduction with VICTOZA. Death from any cause, also a reduction with VICTOZA. This led the FDA to grant VICTOZA or liraglutide a cardiovascular events indication back in 2017. I'd also like to point out that the LEADER trial showed reduction of persistent macroalbuminuria, which was significant. And then the primary composite renal outcomes, which were panels B, C, and D. So reduction in macroalbuminuria, persistent doubling of serum creatinine, and continuous renal replacement therapy all showed significant improvements on liraglutide versus placebo. Looking at the SUSTAIN 6 trial, this was an evaluation of semaglutide or Ozempic. This was IV, or the injectable, excuse me. So this first panel, which was the primary outcome, included cardiovascular death, non-fatal MI, or stroke, showed that semaglutide or Ozempic does have a significant reduction of the primary outcome of all of these. Also showed that it was heavily dependent on non-fatal stroke. So that's panel C here. When we talk about cardiovascular trials, there's a term that I'm sure you're all familiar with too. It's called MACE, and that is major adverse cardiovascular events. So in this trial, it showed that MACE was very heavily dependent specifically on a reduction in stroke. And so we know that patients, type 2 diabetes patients often die from cardiovascular related deaths, heart attack, stroke. And so if you have a patient that has suffered an MI or a stroke, these are drugs they should be on. This led the FDA to approve Ozempic to reduce cardiovascular risk in adults with type 2 diabetes and known heart disease. Moving on to the REWIND trial. This looked at dulaglutide or Trulicity, and this showed a reduction of all composite cardiovascular outcomes, which was significant with Trulicity. Reduction in non-fatal stroke, again, which was significant. And the composite cardiovascular outcome was, again, composite of all of these panels together. So, again, FDA approved Trulicity for primary and secondary major adverse cardiovascular events prevention. So both for primary and secondary cardiovascular prevention. So we just mentioned that our patients that do have type 2 diabetes are at risk of death from heart attack and stroke and major, adverse cardiovascular events. So we can really intervene in terms of primary prevention by putting them on GLP-1 agonists. This is independent of glucose lowering. So even if a person's A1C is at target, this is completely independent of getting their A1C lower. This is to prevent cardiovascular disease or recurrent cardiovascular disease in these patients. So these are older agents that I'm going to go through now. This was the EXCEL trial that looked at Exenatide and Byetta. This failed to show superiority for cardiovascular benefit. However, it did show no harm, and it showed significance for non-inferiority, which is important as well because, we know that not every single agent within this class showed cardiovascular benefit and shows the cardiovascular benefits that I showed with each of the previous trials, but it's important to recognize that it doesn't cause cardiovascular harm. because we know that there are agents of diabetes medicines that do cause cardiovascular harm, right? So if we briefly touch on those, we know that insulin itself, I mean, I love insulin as an endocrinologist, I love it. But insulin causes fluid retention and weight gain. It isn't the best, especially for somebody that may have heart failure or cardiovascular disease. We know that sulfonylureas can predispose to hypoglycemia. Not really a great agent for somebody that already has cardiovascular disease, which could potentially lead to type 2 demand ischemia with hypoglycemia. We also know from the Steve Nissen trial that I presented earlier that the TZDs, or the thiazolidine diones, can cause fluid retention and adverse events to the myocardium. So even though these trials that I'm about to present with the older GLP-1 agonists do not show cardiovascular superior benefit, they don't show harm. Okay, so does anybody have any questions?
Yeah, I was not sure whether I should keep it till the end. Regarding the Albiglutide, the Trulicity, now they have come up with higher dose, like
Yeah. So there's 0.75, 1.5, 3 milligram, or 4.5 milligram weekly. There's
Okay.
4 pens.
Now, actually, I've personally never researched it. I'm just asking that, does it mean that if we keep increasing the dose, all the benefit of the medication is proportional to the dose?
No, not all of the benefits. So as you increase the dose, you'll get a benefit in terms of A1C and blood glucose lowering. You'll get a benefit in weight loss reduction, but the cardiovascular benefit still stands with the 0.75 milligram dose.
Okay. And for a patient like the one which you told, for example, you achieved the A1C goal, okay, and say suppose you achieve the A1C goal with 1.5, would you be inclined to go up higher to achieve till the 4.5 dose, or would you rather just keep it at 1.5?
It's a great question that I get often. And yes, I do. I go up to the highest dose because if you think about a normal A1C and outside of diabetes, a normal A1C is around 4 to 5%. And if you're able to obtain that without hypoglycemia, yes, I do strive for that. And I do increase the dose. I do want to point out though, that there is an A1C target that's less than 7% for most adults. That is age 18 to 65, right? That is variable. There's not a one size fits all for our diabetes patients. You know, say there's a 30-year-old who had a heart transplant and is very sickly and maybe end stage, and there are definitely exceptions to that A1C target, right? But in general, we try to obtain a target less than 7% because that's the magic number to reduce or prevent the adverse, complications of diabetes in the long run. So when you're increasing your GLP-1 receptor agonist, you want to increase it to get to target less than 7%. And I strive even lower than that if possible without causing hypoglycemia. I mentioned that the GLP-1 receptor class does not cause hypoglycemia on its own. I will tell you though that in my clinic, I see a lot of diabetes patients who their A1C is, 14 to sometimes 18. So my patients are usually on 4 shots of insulin a day, plus all these adjuncts, right? And so insulin added on to a GLP or an SGLT2 or a sulfonylurea or whatever, insulin can, in concert with a GLP, cause low blood sugars. So if you're just using an GLP-1 agonist, then yes, you can go up to the 4 milligram weekly dose and strive for the best A1C that you can obtain without doing harm to the patient. Do you understand? Does that answer your question?
It was very helpful. Thank you. You answered many questions of mine in this. Thank you.
Yeah, so I strive for the lowest A1C I can target without adverse consequences to the patient. And the biggest adverse rate limiting step in doing that is hypoglycemia. But again, just remember, most people have an A1C around 4 to 5%, and that's a normal A1C. So in driving it lower, you're not doing harm as long as the patient doesn't suffer all those GI adverse effects associated with the higher dose or hypoglycemia. Okay, so I think that we left off here, correct? Excel. So Excel, I wanted to point out, did not show harm, didn't show cardiovascular superiority, but no damage to the myocardium. This is a blown up y-axis. So this was Elixa or Exenatide or Luxumia. This was one of the older GLP-1 agonists as well. I wanted to point out, did not show significance, but again, did not show any harm. Pioneer 6 was, I mentioned, the new oral GLP-1 receptor agonist. This is semaglutide, or brand name Rybelsus. Did not show cardiovascular superiority. So unfortunately, although these trended towards significance, it did not overall show primary outcome significant for superior cardiovascular protection or cardiovascular superior to placebo. It didn't show any harm, but I think that this really was unfortunate because within the GLP-1 class, we were hoping for an oral agent that could rival the injectables, because there are a lot of patients who fear needles or have injection site reactions, or, you know, the pain of injection even once a week is still hard to endure for a lot of our patients. And so this was a long awaited drug, and unfortunately it didn't show the superiority for cardiovascular benefit like the injectable GLP-1 receptor agonists showed. This was Harmony, and this is Albiglutide or Tanzeum. It is now off the market. Older agent that did also show cardiovascular benefit. So Albiglutide showed, this was the composite outcome of death from cardiovascular cause, MI or stroke. It did show a significant reduction with Albiglutide compared to placebo. And I don't know if you can see in the bottom here, but I labeled each. Can you see me moving the panel of you all around my screen? I'm sorry, I'm trying to move it to a place where we can see the slides better. So I tried to label all these panels, and so A is your composite of death from cardiovascular cause, MI or stroke, cardiovascular death, significant for myocardial infarction, and then stroke. This is a slide to just detail the renal benefit from the GLP-1 receptor agonists. So I'm going to move you again. So the LEADER trial, AWARD, SUSTAIN 6, Elixa, all showed benefits to the kidney. So in terms of reducing macroalbuminuria, preventing nephropathy from worsening or the onset of nephropathy, reduction in urine albumin to creatinine ratios. So overall, you know, your GLP-1 agonist class helps the myocardium, helps the nephron. So case 2, this is, let's see. Anybody have any questions before we move on? Okay. Joe Hart failed. He's 38, Caucasian male, presents for an evaluation of uncontrolled type 2 diabetes. He's referred from heart failure clinic. His A1C is 9.2%, although blood glucose trends show improved control since beginning metformin. Blood glucose is now 150 to 170. There's no diabetes complications to date. His cardiac history includes newly diagnosed non-ischemic heart failure, no history of coronary artery disease, also has hyperlipidemia, hypertension, sleep apnea. He's currently treated with metformin 1 gram twice a day, which is his maximum dose. Blood pressure, vital signs are all stable. He is overweight and his GFR is within normal limits. What is the next best step? So do we want to start a GLP-1 receptor agonist and continue metformin? Do we want to start an SGLT2 inhibitor and continue metformin? Do we want to stop metformin because blood glucose looks awesome? Do we want to start Januvia, which is a DPP-4 inhibitor? Do we want to also continue metformin? Or do nothing and send him back to cardiology and tell him his cardiabetes is well controlled? Anybody have any thoughts? Again, nothing is wrong. We can have a discussion if you have questions about the case. There are so many different ways to skin a cat or treat diabetes. So we can talk through all the answers. So
We got a chat in saying A, D, or B.
I think that you should apply for our endocrine fellowship, Mithra. Okay, you would be wonderful. So he's 38 years old. He has a history of heart failure. A1C is very uncontrolled, although blood sugars are now trending much better and lower than what that A1C is reflecting. And again, newly diagnosed non-ischemic heart failure. He does not have atherosclerotic disease. So we mentioned GLP-1 receptor agonists are really beneficial for atherosclerotic disease, both primary and secondary prevention of cardiovascular disease. SGLT2 inhibitors, very beneficial for heart failure. Metformin, first-line therapy for type 2 diabetes. So stopping metformin, we wouldn't want to do that. His blood sugar is under better control with metformin, so we wouldn't want to stop metformin. His GFR was also normal. Starting Januvia, Januvia doesn't have cardiovascular benefit, and some of the DPP-4 classes have actual harm, which can be seen in the ADA guideline table that I set up for you at the beginning of the slides. So do we do nothing and send him back to cardiology and tell them it's controlled? Absolutely not, because we know now that we have drugs that actually treat diabetes and heart failure, and that would be our SGLT2 inhibitor class. So the answer is B, to start an SGLT2 inhibitor even if his A1C, say it was 6.5%, and he has a diagnosis of heart failure, you still treat with an SGLT2 inhibitor because these drugs have an independent FDA approval to treat patients with heart failure outside or independent of diabetes. So if his A1C and he has no diabetes, A1C is normal, he does not have diabetes, you still treat with an SGLT2 inhibitor. I'm gonna get out of the sunlight here. So we did do that. This was my patient in clinic, and he went down, you can see, from 295 pounds from 301. His A1C went from 9.2% to 6.1%. And that was with the addition of an SGLT2 inhibitor. So let's go through the SGLT2 inhibitors again. This is just for your reference. Dapagliflozin, empagliflozin, ertugliflozin, and canagliflozins. These are all the gliflozins. Let's zoom in on one of those, that initial ADA slide that I gave you at the very beginning to our SGLT2 inhibitor class. It is efficacious, but remember I told you that the efficacy of this drug, it's not just for A1C lowering. You can do a lot of benefit in terms of heart failure and renal disease with this drug. So yes, it has efficacy, intermediate efficacy for A1C lowering, but the benefits to the myocardium and the nephron are tremendous. It does not cause hypoglycemia on its own. There is weight loss associated with it. This drug acts like a diuretic, so you do have weight loss. The cardiovascular effects show that there is a benefit in terms of atherosclerotic cardiovascular disease with both empagliflozin or Giardiance and canagliflozin or Invokana. The heart failure benefit is with all three, empagliflozin, canagliflozin, and dapagliflozin. They are costly. The benefit is that they are oral. In terms of renal benefits, these three do benefit. They have different renal dose adjustment thresholds. And so I would just caution you, kind of make sure that with each person's GFR that you're checking the GFR prior to dosing. And then the additional considerations with this drug class are to discontinue before any scheduled surgery to avoid the potential risk of DKA. And I want to point out that, again, we're talking about type 2 diabetes. So there is a DKA risk in these patients. It is rare, but it can be seen. And this is what they call euglycemic DKA, because the threshold for the glucose is a little bit lower and can be less than 250, and the patient still can be in a ketosis state with these drugs. And if you do develop ketosis on these drugs, they should be discontinued. There was a risk of bone fractures only noted with canagliflozin. It doesn't seem to be a class effect. And then you can definitely see genital urinary infections, risk of volume depletion or hypotension. Cholesterol can slightly rise with these drugs. And there is a risk of Fournier's gangrene. These genital urinary tract infections occur because you're sucking the glucose out of the bloodstream and pouring it into your nephron. And wherever you have a high glucose load, you have a high risk of infection. And so yeast infections and urinary tract infections can be seen. The good. So this is just a simplified slide of the previous ADA guidelines. So the good is these cause weight loss, blood pressure reductions, renal benefits, cardiovascular benefits. The bad, fractures, infections, excessive urination, volume depletion, increasing cholesterol, Fournier's gangrene, and DKA, which is rare. Things to just let our patients know. So looking at the benefits of SGLT2 inhibitors on the myocardium, there's thought to be decreased volume overload, decreased wall stressor, decreased fibrosis, an increase in natriuresis. And I'm going to go through the nephron effects in more detail on the next slide. This is the tubuloglomerular feedback system. A, in normal physiology, B, in diabetes, and then C, treatment with SGLT2 inhibition and diabetes. So the way that the SGLT2 inhibitors work is they basically increase the amount of sodium and glucose reabsorption at the proximal part of the nephron, leading to decreased sodium delivery to the distal part of the nephron or the macula densa. And when that happens, it kind of simulates like a dehydration effect from low sodium. So then you have what's this afferent vasodilation, and that prevents the hyperfiltration that's seen in diabetes, and hence, you know, prevention of damage to the nephron. So looking at the SGLT2 inhibitor trials, EMPA-REG, CANVAS, DECLARE-TIMI, DAPA-HF. So EMPA-REG looked at empagliflozin, or brand name Giardiance, and it showed significance all across the board. So in terms of primary outcome, which was cardiovascular death, non-fatal MI or stroke, And this was a composite of, all of these panels. So death from cardiovascular cause, death from any cause, hospitalization from heart failure, all were significant with empagliflozin, leading the FDA to approve Jardiance to reduce cardiovascular death in adults with type 2 diabetes. This is Canvas. It looked at canagliflozin or Invokana. It did show significance for Invokana in reducing death from cardiovascular causes, non-fatal MI or non-fatal stroke. Declare TIMI. This was dapagliflozin or Farxiga, showed again significance in terms of cardiovascular death or hospitalization from heart failure. Also showed significant renal reduction of macroalbuminuria, reduction in a patient's GFR. This led the FDA to approve this drug to reduce the risk of hospitalization for heart failure in diabetics. So you can see the trend of this being really a class effect in reduction of heart failure hospitalization and improvement of kidney disease in patients with diabetes. Credence was a trial that looked at canagliflozin or Invokana, and these are really the renal outcomes that I wanted to just highlight. So primary composite outcome was end-stage renal disease, a doubling of the serum creatinine, renal or cardiovascular death showed significant findings for Invokana or canagliflozin over placebo. Also death from cardiovascular causes, which we covered in our previous Canvas trial here. DAPA-HF, this was dapagliflozin or Farxiga. Again, outcome of worsening heart failure, hospitalization, urgent visits resulting in treatment for heart failure or death from cardiovascular causes was significant with dapagliflozin or Farxiga. So I put this busy slide in. It's from the ADA. I think it's a great slide to reference when you're in a busy clinic. If you have a patient that comes in with type 2 diabetes, there are a billion choices. Like I said, lots of ways to skin a cat. If you look at the left-hand side, first-line therapy. So I'm sorry, I kind of got ahead of myself there. Let's just talk first-line therapy. Always going to be diet and exercise and lifestyle changes. Refer your patient to diabetic education. That's our staple, that's the first-line therapy. After that, do they have a high risk of cardiovascular disease, established cardiovascular disease, CKD, or heart failure? If they do, you want to go over to the left side of the algorithm. If they have atherosclerotic cardiovascular disease, remember your GLP-1 receptor agonists are what you should be considering. If you need to add on therapy, SGLT2 inhibitors with proven cardiovascular benefit. And you can go down in more detail and review, the small reading in these algorithms, but we covered most of these trials to help you with this. And then if the patient has heart failure, consider an SGLT2 inhibitor with a proven benefit. If the patient has CKD, both the SGLT2 inhibitor class and the GLP-1 receptor agonists have proven benefits for kidney disease. So either or. And then if the patient does not have these, which in my clinic, I really don't often see patients that are not plagued by some kind of diabetic complication, but in primary care clinics, if you do not have any of these three, you can tend to go over more towards the right side of the algorithm. If you need to eliminate, hypoglycemia, consider these agents. Oops. If you want to promote weight gain, if you want to promote weight loss, here in the light blue, they give you agents. Typically, the best weight loss agents for diabetic patients are the GLP-1 receptor agonist class. They're so good at helping with weight loss that those drugs actually got rebranded by pharmaceutical companies. And you may have heard of the new, not new, but the agent called Saxenda. That is LIRAGLUTIDE daily at a really high dose, 3 milligrams would be the max dose. So Saxenda is for treatment of obesity only. That's for patients that don't have diabetes. So, in a diabetic patient who's really hoping to lose weight or having trouble losing weight, GLP-1 receptor agonists have good efficacy for weight loss. SGLT2 inhibitors also help with weight loss through their diuretic action. But, you know, in thinking of our whole diabetes, you know, all the classes that we have to treat diabetes, there are a lot of drugs, again, that cause weight gain and fluid retention. So insulin causes weight gain and fluid retention. Thiazolidine diones, they cause weight gain and, you know, fluid retention. Sulfonylureas cause hunger and weight gain. And so our diabetic population doesn't need, you know, weight gain. Most patients are really struggling with weight loss. And so using a GLP-1 receptor agonist or an SGLT2 inhibitor is really beneficial for this population of patients. And then, you know, I am not a fan of sulfonylureas or TZDs, but if cost is a major issue, and a lot of times as clinicians, we are backed into a corner and we have to use these agents, they're cheap, along with metformin, which is $4 a month. If we're backed into a corner, then yes, we have to use sulfonylurea and TZDs, but again, not helpful for kidney disease, heart disease, or weight. So these are our last options here. So choices. This just boils down the ADA algorithm. You know, do they have atherosclerotic cardiovascular disease, CKD, or heart failure? Use your algorithm over here to the left. In summary, if your patient has atherosclerotic disease, use a GLP-1 agonist, right? If your patient has heart failure, use an SGLT2 inhibitor. If your patient has renal disease, use both. Anyone have questions? That was a lot to cover in an hour. My plan was to try to break it up into 2 segments, but we didn't have any cases, so I'm sorry. That was a lot of studies and a lot of stuff.
That was wonderful. Thank you so much.
Oh, sure. Lauren, you have a question?
Yes. So just going off what you just said, I worked in primary care, and so I had patients that would benefit from the GLP-1s, SGLT2s, but I could never get them covered. Do you have any tips or tricks as far as trying to get that done?
You know, I don't want to toot my own horn, Lauren, but I'm going to for a second. I got so discouraged in writing appeal letters for GLP-1 agonist coverage because in my state, what would happen is if a patient was on 4 injections of insulin a day, they weren't allowed to have add-on GLP-1 agonists. And so I think I had written maybe my 200th letter of appeal to insurance. And finally, I was so angered that I decided to go directly to the insurance company and ask to speak with them and have their time. And I did. And I presented a version of what I just presented to you to the insurance company. And I said that our diabetes patients urgently need GLP-1 agonist coverage, and me not writing it is knowing that I'm not giving them primary prevention of cardiovascular disease. And insurance reversed their policy in my state. So I want you guys, I tell you this not to toot my horn, but to tell you this because you have a voice. As a primary care doctor, you need to voice your opinions and tell insurance and write insurance. And I know that it's time consuming, but if we do not push back and if we don't show evidence-based guidelines, then we will be forced to do algorithms based on insurance company policy and not based on evidence. And so I urge you to write to your government, and I urge you to write to your insurance company and go to them and change the policies, because that's what it's going to take for insurance to allow SGLT2 and GLP-1 coverage. And in my opinion, my very humble opinion, prevention of cardiovascular disease and renal disease is a lot less costly than allowing a heart attack to occur or end-stage renal disease to occur. It's a lot less costly to a hospital, you know, and so that is, unfortunately, a lot boils down to money. So when you present the data on this, I think it's irrefutable. And I just urge all of you to talk with your, you know, write the letters, ask for insurance time, you know, don't go unnoticed. That's how things change. If you keep getting your hand slapped no, change it. Change the policy if you know it's wrong. That's my only advice.
That's really inspiring. Thank you, Dr. G. Dr. Pollywall, did you have a question too?
Yeah, I face the same problem with Dr. Anderson faces, but I hopeful with this new guideline, hopefully they will get on board, because
Yeah.
when I've been asking for this weight loss and cardiac protection, renal protection,
Yes.
the insurance don't pay attention to that. I mean, they are not counted. Hopefully 2021 will be better. My
Yes.
question is specifically with the SGLT. What do you tell to your patients when you warn them about the genitourinary infection or the Fournier's gangrene? And what is the threshold when you really stop them? Like
Yeah.
in females, it's common to get yeast infection and
Right.
UTI otherwise also.
Right.
But at what point do you say, no, this patient, I will not put on SGLT for
Great
the risk of...
question. Great question. Thank you. So I had presented a case earlier about a patient who had an A1C of 11.2%. And I mentioned that I wouldn't have started an SGLT2 inhibitor at that point because the diabetes was so uncontrolled and the patient would have been urinating excessively and it would lead to non-compliance with the drug. I don't start an SGLT2 inhibitor above an A1C of greater than 9%. I use it adjunct agents like insulin. You know, if your A1C is 9 to 10% or greater, you remember that the GLP-1 agonists and the SGLT2 inhibitors, they're not going to lower your A1C 5 points to get you where you need to be, right? Because these drugs only have efficacy to lower your A1C maybe 1 to 2.5%. So you need insulin. Insulin has no threshold or ceiling on the amount that it lowers your A1C down to 7% or less, where it should be in all adults, right? So I use insulin 4 shots a day, bringing down the A1C. Once it's less than 9%, then I add on an SGLT2 inhibitor, because that's going to cause less dehydration and less urination all the time because you have a more controlled blood sugar. So I don't use the SGLT2 inhibitor to attain good control. I use it once their blood sugar is controlled to prevent heart failure, hospitalization, and poor renal outcomes. So get it down to 9% at less, and then add on your SGLT2 inhibitor. Type 2 diabetes itself is a state of multiple infections, right? You have a high sugar in your system, so you're predisposed to urinary tract yeast infections and Fournier gangrene, even without an SGLT2 inhibitor. And I tell patients that, you know, at baseline, you're at a higher risk of these things, even without the SGLT2 inhibitor. But if you should develop it on the SGLT2 inhibitor, please call me. If you get more than 2 infections in a year, we stop the drug, or one severe infection, 1 Fournier gangrene, I stop it. That's how I approach it in clinic.
Thank you so much, Dr. Giordano. Was that everything, Dr. Pollywall, or did you have a follow-up question?
No, that's and last thing is, I wanted to use Saxenda for obesity, but it was never approved by insurance.
I know.
Okay, are you using it right now, or are you getting any success?
So one of our carriers, PEIA, has a plan where it is covered much better than it's ever been. So yes, I do use it, but with limited use. It is still, so the obesity drugs are still considered designer in a way. It's so hard to get them covered in clinic. I haven't had great success with Saxenda, but remember that if you do have a patient with diabetes, you can use, so obesity, you can treat with Saxenda. Type 2 diabetes, you can treat with the GLP class and have better coverage because the patient has diabetes. So you can use Ozempic, or now with the 4 pens of Trulicity, you can go all the way up to the 4 milligram of Trulicity and get it covered under the diabetes diagnosis, whereas obesity doesn't have great coverage for any of their medicines. You know, phentermine is a really cheap medicine, so, you know, that most people end up going on phentermine or Qsymia, phentermine topiramate. But yeah, Saxenda coverage is really limited. Saxenda also is once a day. So once a day versus like your Trulicity, which is once a week. If the patient has an elevated A1C, use the diabetes diagnosis to get your drugs covered.
Thank you so much, Dr. Giordano. We are at the end of our session hour, unfortunately, but I wanted to thank you for that great didactic. I know you went through it all today in one session, so maybe next time we can try to have some participants submit cases or even questions through the online case submission form. That would be awesome. I know it can be a little daunting at first when you take a look at that form, but always email me. I can go through it with you. And you certainly don't have to fill out every box in that form. So I hope that's a little more reassuring for you all. Our next session will be on January 27th from 12 to 1, and we'll see you guys next time. Thank you so much, everyone. Thank you, Dr.
Everyone.
Bye.